Okay, good morning, everybody. We will start the session. So my name is Professor Paul Tipton. I am Clinical Director of Tipton Training Limited. I'm also President of the British Academy of Restorative Dentistry. So today what we're going to be doing is going through a particular case study, an interesting case study that involves restorative and aesthetic dentistry principles. And we will take this case study from the initial beginning all the way through to the end. At the end of the session, I'm happy to take some questions. So let us start off with our patient. And it's always important to look at the patient, look at the patient's face, and make some sort of decisions about what the patient looks like, how old the patient is, etc. So let's look at our lady. I'll just come to her signs and symptoms. We'll then come back to her face. She's aged 59. You're going to see in a minute that she has a gummy smile. Also, there's a centerline discrepancy, not a huge one, only a couple of millimeters. She's got loss of vertical dimension, severe wear, especially on her anterior teeth. She's a bruxist. She's coming up to a very big birthday, and therefore she would like to have a cosmetic improvement to give her a boost as she goes into the next decade. And if we look at all the rest of her teeth, she realistically needs a full mouth reconstruction. She's got missing teeth. She's got teeth with large restorations in place. So let's just go back and look at her again. So what can we see? Attractive lady, okay? We can see, from my point of view, she's got good cheekbones. I'd suggest that the pallor, she's quite pale. The skin tone a little bit sweaty. Eyes a little bit sunken into the head. So overall, a good-looking lady, but maybe we can do some improvements to her. Not just to smile, but also to the facial aesthetics. So again, we look a little bit more closely. And start off with the center line, and we can see our center line is maybe 1 to 2 millimeters off. It's around about in the middle of one of the lower incisors. We can also see from this picture in a normal smile, this isn't a huge wide smile, but in a normal smile she's showing a little bit more gum than ideal. So our starting point with all of these things is exactly the same, and please excuse me if you've heard me talk about this before, but it is repetition, and it's only with repetition that eventually we start to do things the correct way, and it becomes the norm. So our norm for this lady who is interested in having some sort of makeover is initially some photographs. We may well decide to do some cosmetic imaging as well, to show her what the end result will be, and also to get some mounted study casts done, mounted around RAP, so we can start to look at the occlusal schemes that we're going to be potentially introducing to her. So we take our face bow, we take our upper and lower alginates. Important when you're taking the face bow that you make sure that the top part of the face bow is parallel to the eyes or to the corners of the lips, the intercommissure line, so the technician can start to mount them and see straight away the orientation of where the eyes are. In this instance, we want to work towards the orientation of the interpupillary line. And we get our study casts, our mounted study casts. So let's start now to talk about the aesthetic requirements. So in a case like this, she's got there are several ways in which we can start to improve her smile. We can work on the teeth and also on the face. I'll leave the face a little bit later. So let's just look at the teeth and the smile. First of all, if we just look back, she's got a gummy smile. We can also see that the teeth are in the wrong proportion. Now, if we look at what the correct proportion should be, you know that the width to length of a good-looking central incisor should be about 75 to 80%. Okay, we have that ratio. If we look here, then I would say that either the width to length is around about 100%, or even potentially with this tooth, the width is longer, is greater than the actual length of it. So we have some proportion problems here that we need to work out. We've also got some abstraction lesions going on. You'll see that she's a clencher and grinder. And we've also got occlusal plane problems. Look at our occlusal plane. Our occlusal plane from the molar goes up a little bit. It then comes down. It then goes up a little bit and then comes down again. So we've got a wavy occlusal plane. Remind yourself what an uneven occlusal plane means. Okay, and I talk an awful lot, as you know, about having an even occlusal plane to make sure that teeth disglued easily. So very, very important that as we're doing our restorative dentistry, we treat the mouth as a whole, we look at the masticatory system as a whole, and that means that we have to have even occlusal planes. Why? Because they disglued very easily with shallow guidance. Shallow guidance, that's the angle of the canine, the palatal aspect of the canine. Okay, the palatal aspect can look like this, very, very steep guidance. It can look like that, very, very shallow guidance. What does the canine need to do? It needs to be able to disglued the opposing side, the non-working side or balancing side. So we want to have guidance which is as shallow as possible, but still disgludes. And if it's shallow, then that means that the lower canine, as it slides down the palatal aspect, there's no stress in the masticatory system. Imagine now if we have a very, very upright canine. The palatal aspect is very, very steep. That means here's my lower canine. Then our proprioception says to the jaw, to the mandible, move to the left-hand side. The mandible wants to move to the left, but it comes across a near vertical wall. What happens then is, yes, mandible does move to the left, but as it's moving, it has to come down at a steep angle. That creates stress everywhere. That creates stress in the joints, that creates stress in the muscles, that creates stress around the periodontal ligament, and it also creates stress in the actual canine tooth itself. However, if we can take an angle from there, move it to there, that's a much easier movement and it takes the stress away. So we want even occlusal planes so that they disglued very, very quickly and easily. So at the moment, we've got poor aesthetics at the front because the shape of the teeth are incorrect. We've also got a problem with the golden proportion, or if you like to look at it, the golden percentage. If we look back again here, then we should be having the width of that central to the width of the lateral should be 1.6 to 1. The width of the lateral to the canine, 1.6 to 1. At this stage, the lateral looks a little bit too wide, possibly the canine a little bit too thin. Again, on this side, 1.6 to 1, 1.6 to 1. The canine is again a little bit too thin, and maybe the lateral incisors are a little bit too wide. So we have golden proportion problems. And again, remember, from the mesial of the fore to the mesial of the fore there, that space that needs to be occupied by the 6 teeth, then that space should be occupied by the centrals, both 25%, the laterals, both 15%, and the canines, both 10%. That gives you that beautiful golden proportion or golden percentage. So we've got problems there that we need to address. How are we going to address them? We're going to address them in 2 ways. We're going to address them either by diagnostic waxing or by diagnostic waxing and also cosmetic imaging. So if we do our diagnostic waxing, it's important we know our end result, and therefore we have to tell the technician exactly what I want the end result to be. It's no good going to the technician and saying, I want to do a diagnostic wax up, please do one. You need to spell out to him exactly what that wax up entails. Another one with a golden proportion is to make sure that the width of 2 centrals to the length of 1 central is again 1.6 to 1. If we look now at the case that we're dealing with, here's our midline that's off by 1 to 2 millimeters, and we look at generally the width to length ratio, that it should be 1.6, the width of 2 centrals to the length of 1. We're here at about 1.8. So that means again that either the width needs to be reduced or the height increased. We look at the rest of the mouth, and this is what we can see. we can see that we've got a lot of wear taking place. There's probably erosion in there as well. If we see this cupping that's happening, then that's erosion. And when we see attrition or wear, bruxing, and erosion occurring at the same time, that's usually a good indicator that we're losing vertical dimension. So we want to be thinking about increasing vertical dimension here. In the upper jaw, we can see large amalgams. We've got some fractures in the teeth where the large amalgams are. So all of these teeth are going to have some form of occlusal coverage. And we've got a tooth missing here, and we've got a tooth missing there. So we're going to be thinking about bridge work or implants for the lost teeth. So let's talk about our vertical dimension, and we need to choose the vertical dimension that we're going to work at. So the first vertical dimension that we can work out is the existing vertical. Now, if that means I'm going to work at this existing vertical, then it means at the moment where the lower incisors are now contacting the upper palatal aspects, upper incisors, for me to put some restorations in place, I'm going to have to take more tooth tissue away. So if I was to put some crowns on here, working at the existing vertical, the first thing I'd have to do is take 2 millimeters off the incisal edge of these already worn teeth. And that sounds counterintuitive. It's not the sort of thing that you particularly want to do in a wear case. Go and take more tooth tissue away just so you can put porcelain or put composite back. So I'm going to be increasing the vertical dimension in this case for 2 reasons. Number 1 reason is that I can create space so that I can minimize my tooth preparation. And the second one is that I can improve facial aesthetics. The third way that we can do it is we can always work around RAP. And remember that we have these options. 90% of our patients will have a slide from RCP to ICP. Of those 90% will actually have a vertical slide, which means that when you take somebody back, so the condyles around RAP, you tap them together and hold them. So the first point of contact, retruded contact position, RCP, you'll see space between the rest of the teeth. Now it's possible also to go and just work to that one position. So you're in RAP, the condyles there, you've got one tooth of contact somewhere, the rest of the teeth are all apart. We work to that position, and then we can build all the teeth up into the correct intercuspal position, and intercuspal position around retruded axis position. But that depends again on how much space you require and also how much space you have on that vertical slide. If your vertical slide is only half a millimeter anteriorly, then that does not give you enough space. So you need to have an adequate vertical slide, which is usually about 2 millimeters anteriorly we would consider to be adequate to add material onto the incisal edges as we do our preparations. So we need to choose a vertical to work at, and we can choose any of these. In my particular case, I'm going to increase facial aesthetics, and that will also give me the space to do my restorations without having to do any occlusal or incisal or palatal preparation. So I will do my full mouth reconstruction, but by minimizing the amount of tooth destruction I'm going to do. So if we're looking to increase the facial aesthetics, then how do we do that? Well, the first thing that we should realize is that a good looking face is in proportion. The 2 things that we talk about for beauty, for aesthetics, the 2 words which are so important to us all is symmetry, and that's symmetry across the midline, and that's also proportion. And for proportion, we can look at teeth-wise and have the golden proportion, and we can also look facially. And a good-looking face has the proportion of equal thirds, and that's hairline to bridge of nose to base of nose to chin should be equal thirds. So we can do our measurements, and we can look and say, okay, the hairline to bridge of nose to base of nose to chin, that base of nose to chin looks slightly less. We can do the actual measurements, and we can take a ruler or some dividers and measure. And then we can always increase that lower third of the face. If we find that it is reduced, increase it to the same size as the middle third. If it is exactly the same size, then we can always add a little bit more on. And in this case, the size is more or less the same, so we're in equal thirds, but by adding 3 to 4 to 5 millimeters in place, what it does is it just stretches the muscles, stretches the lips. Just look at the difference here facially between one side before and after we've increased the vertical dimension. Now, we've not done this increase in vertical dimension. These are not the end photos. We are now testing this out. And it's really, really important that you do test these things out. We can't go to a patient and just say, we're going to increase vertical dimension and therefore we'll just do it. Okay, we need to test it out so the patient can actually see what is happening. And we do this very, very easily with some wax. So take some Moico Beauty Wax. When you want to next do a full mouth reconstruction or a large partial reconstruction, and you want to increase vertical dimension, get some Moico Beauty Wax. Important, it's Moico Beauty Wax, extra hard wax. So when it sets very, very hard. Roll it up into a roll, into a carpet, bend it into a U shape. We then go and put the wax into the upper jaw. Push it onto the upper teeth. Once we've done that, just make sure it's not impinging on the upper lip anywhere. We then lie our patient down, manipulate our patient to RAP, and gently ask them to close into the wax. Not all the way through it, because our wax is warm, but just into it. Once we've done that, then take the Moico Beauty Wax out, put it into some cold water so it goes hard, sit the patient back up again, and put the Moico Beauty Wax back in place and ask the patient to close together. And ask the patient now to bring their lips together. And as the patient brings their lips together, the lower third of the face will get stretched. And as we get stretched, we have this change in appearance. And the lines, for me, I'm looking closely, the lines here seem to have reduced. The lips are a little bit fuller than they were previously. Okay, we look and we have a better profile here. We have a certain greater fullness. We've gone from maybe class 3 to a class 1 style of relationship. And if it's too much, then we simply ask our patient to squeeze and squeeze a little bit more so the vertical dimension comes down a bit and comes down a bit until the patient feels that's enough. They can always take that wax home and they can always go and slip it in at home, look at themselves in the mirror, come back the next time. We're in no rush for this. Come back the next time and we can discuss it again. But eventually you will decide on a vertical to work at. And once we want to work at that vertical, then we'll mount the models with that jaw registration. As we mount the models, we'll put the jaw registration between them, and then that will tell us exactly the vertical that we're going to work at. And our diagnostic wax up will be done at that vertical, our prototypes will be done at that vertical, and our definitives will be done at that vertical. So if we increase vertical dimension, it means that our teeth no longer contact. So therefore, we're working with space between the teeth. And with that space between the teeth, obviously, the end result will be that we need to get our teeth to contact. Okay, we need to have a good bite, a good occlusion. So whereabouts in that space are we going to put the teeth? So we now come to this discussion again about occlusal planes. And the plane of occlusion determines treatment plan. And by that I mean if we have any teeth that are sticking up or lower down from the plane of occlusion, remember that we need to either build them up into the ideal plane or reduce them if they're too long, so that again at the ideal plane. Why? Because an ideal plane of occlusion discludes easily and is comfortable long-term the masticatory system. If we've got a reconstruction which is sympathetic to the masticatory system, it will work in harmony with it and it will last longer. And that's what we want. We want comfort, longevity. I'll come back to that other word that we talk about, predictability. Shallow guidance gives us predictability. What gives us shallow guidance? Even occlusal planes. If one tooth is over-erupted, we have to increase guidance to try to disclude that over-erupted tooth. So planes of occlusion will give us our treatment plans. The plane of occlusion determines the aesthetics of the case, how much tooth, upper tooth or lower tooth, should be shown when the patient goes The plane of occlusion gives us the amount of tooth reduction that we need, because we know exactly where our new occlusal plane is. Do we reduce the incisal edges, or do we just build them up? The plane of occlusion gives us the need for any crown lengthening that we need. So really, really important we think about planes of occlusion as quickly as possible. The plane of occlusion that we work to is always the lower plane of occlusion, first of all, because that's the one that has the curve of Spey, curve of Wilson in. And we know that the curve of Spey, the antero-posterior plane of occlusion, that curve passes through the retromolar pans. So it's important that we get the shallow plane of occlusion, but also as anatomically correct as possible. So we go to 3 landmark points for a plane of occlusion. We need 2 posteriors and 1 anterior. The 2 posteriors are going to be halfway to 2/3 the way up the retromolar pads, because that's where the patient's natural curve of Spey goes through. So let's use that. And then the anterior reference point is going to be whereabouts that lower incisal edge should be. The average patient, it's 1 to 2 millimeters above the lower lip, but we have to determine that based on the age of the patient. If I have an older patient, we see more lower incisor. A younger patient, less lower incisor. So we have to look at our patient is 59 years of age. She would love to have a makeover that takes maybe 8, 9, 10 years off her. So she would like to now look like she looked when she was 50 years of age. So when we're talking about the anterior reference point now, we have to look and see how much tooth tissue would she show normally during the M position, M, for a 50-year-old, not a 60-year-old, because we want the age of the reconstruction to be 50, not 60. And that's around about that 2 millimeters, 1.75 to 2 millimeters. So we're going to have our third reference point as about 1.75 millimeters above the lower lip. And that will give us our 3 reference points and our occlusal plane. We then need to put the curvature into it. And as you know, we've spoken about this many, many times. We've got our Boyle's plane analyzer, which you can get from your lab technician. Your lab technician has these, and this is what he uses to wax in the occlusal planes when he's doing dentures. And the Boyle's plane analyzer is constructed a piece of plastic, so it has in that piece of plastic the curvature, buccolingually curve of Wilson, which is a curve of 4 to 4.5 inches radius, and again the posterior curve of Spey, again 4 to 4.5 inches. And what we do is we wax up always 1 lower incisal edge, first of all, to that correct 1.5, in this case 1.75 above the lower lip. Wax 1 tooth, put the Boyle's plane analyzer then onto those 3 reference points and wax up all of the lower teeth to it first of all. So here's our space, and we will see at the moment she's probably not quite showing enough lower incisor for her age, and therefore we'd like to maybe put an extra 1 millimeter of lower incisor there, half to 1 millimeter, so she's showing about 1.75. In the upper, she's showing about 2 millimeters. Again, probably for her age of 50, we need to just reduce that by around about 1 millimeter and give her the right smile for the age she's looking for, which is around about 50 years of age. So before we now go into our restorative work, we need to look at some pre-restorative work. And for that, we're talking about crown lengthening. We mentioned in this case that she's got a very gummy smile. So we want to get rid of that gummy smile. So this is her smile, and we can see a lot more gum on the right-hand side, not too bad on the left-hand side. So our aim is going to be to take some more gum away from the upper right-hand side to make it match the upper left-hand side. In an ideal world, we would probably want the upper lip and the gingival margins to be more or less at the same level. Or in fact, even if possible for us as restorative dentists, if the upper lip covered the gingival margin, that would be even better for us, because that would allow for a little bit of recession long term without causing aesthetic problems. However, we need to look generally at what other people think as well. And from the science, we can see that the lay population, the rest of the people out there, would judge a gummy smile when they see 4 millimeters or more. I think dentists are slightly different. We're looking here and we can probably see about 3 millimeters of excess tooth tissue, excess gum tissue. And whilst the symmetry is wrong, if this amount of gum tissue is all the way around, most of lay people would say it's not particularly gummy. However, dentists, I think, have got a different idea. So our idea now with the crown lengthening is to go and take some excess gum away from the upper right central and lateral, also a little bit from the upper left central and lateral, to make sure we get our proportion correct. Remember those incisal edges, if anything, I want to shorten them slightly, certainly not lengthen them. So for that, we go to our diagnostic wax up, and we also create a periodontal guide, and this is our crown lengthening guide. So this is made to our diagnostic wax up, and then this can go into the mouth, over the tissue, and it now shows the periodontist exactly where the end result of the crown lengthening needs to be. So he places this in the mouth. There's very many different types of periodontal stent, surgical stent, that your periodontist can use. He will probably have his own different style, which he prefers. This is one of many of them. So it's made from a wax up, an initial wax up, so we get the width to length ratio, our golden proportion correct. This goes over the teeth, the existing teeth, and he simply, with an indelible pen, marks around where the new gingival margin should be. He then takes a scalpel and eliminates the excess soft tissue. Then he raises his flap and he takes away the same amount of tissue, which is in this case around about 2 millimeters or so. And then he sutures back in place. And of course, we need to leave a reasonably lengthy amount of time between this appointment and when we do our definitive restorations. And that length of time is a minimum of 3 months. Remember, we need 3 months for healing, 6 months for maturation. So somewhere between the 3 and 6 months is when we'll go back in and do our definitives. Doesn't mean to say in the meantime we can't do our prototypes and get our patients to have a better looking aesthetic result on prototypes whilst the patient's healing. We're certainly going to do that. But I won't do my definitives until sometime between the 3 and 6 month period. So we now have our soft tissue that has been reduced and taken away, and we now should be having nice even gingival margins. We started out in this area and we've now gone to this particular shape, and that's our periodontist. One thing we should always say with periodontal work is that it is an imprecise art in terms of we cannot exactly tell the restorative dentist or the patient where the gingival margin will end up. It will be grossly in the correct position, but you have to also say that very often we will have to do a second procedure if we want it to be exactly in the right position. So the first procedure is a gross one. Sometimes if that's not good enough, we need to do a second procedure to get it exactly right. So we're now waiting. So that's one of the first things that we do, our periodontal surgery, because that's going to determine how long it's going to be until we can do our definitive restorations. And now we're going to start doing our waxing, our detailed diagnostic waxing. And as always, we start with the lower wax up first of all, and we use those 3 reference points, our Boyle's plane analyzer, to get our diagnostic wax up completed. And you can see here, we've got a very nice, even occlusal plane, no teeth sticking above it. We've got a nice, gentle curve of Wilson, cusp tips down of buccal to lingual to lingual to buccal, a nice curvature of 4 to 4.5 inch radius, and we've got our antero-posterior curve of space. So that's all completed, ready to go. Once we've done that part, then we'll do the upper, and we'll bring the upper down to the lower. Remember, at the moment, we're increasing vertical dimension, so the upper teeth do not contact the lower teeth. Once we've got our lower occlusal plane worked out properly and the waxing completed to the ideal, then we bring our upper down to the lower. We start off with the upper anterior. We again make reference to where the incisal edge should be in the M position. And in this case, we want to probably reduce it by about 0.5 millimeter or so. So that means on the mounted study cast, we'll take half those incisal edges of the upper central incisors. The lateral incisors maybe will make just a little bit shorter than that, and the canines will be the same length as the centrals. We complete the upper anterior wax up. We then bring the palatal aspects down to meet the lower incisal edges, the new lower incisal edge position that we've made, which is slightly higher than it was previously. And then we get contact. We now produce the guidance. Our technician waxes nice, even, shallow guidance into the upper 3 to 3. The final stage, we bring the upper posteriors down to the lowers. So we complete our diagnostic wax up now in the upper jaw, so that we've got the correct incisal length, we've got the correct width to length ratio, 75 to 80%. We have the correct golden proportion, 1.6 to 1 to 0.6, or 25, 15, 10% of the space between premolar to premolar. And of course, this is the most important part of everything that we do, the treatment planning stage. If you don't get the treatment planning stage correct, then the final definitive case will not be correct. So this is so, so important. We spend time and effort, and the more time and effort we put in at this stage, it pays dividends at the end, because the patient knows what it's going to look like. I know what it's going to look like. The technician knows what it's going to look like. We're all working to the same goal. Once we have our wax up completed, upper and lower, we're then going to go to our prototype. And our prototype preparation guides for us to work inside the mouth and create the same relationship to the wax up. So we have our prototypes made now. And again, as always, the prototypes in each arch are made in 3 different sections. So we have our upper 3 to 3 splinted together as one section. We have our upper right posterior splinted together, upper left posterior splinted together. In the lower jaw, again, lower 3 to 3 splinted, lower right splinted, lower left splinted. And we will go in and do the preparations and convert her to her prototypes using opposing quadrants or sextants at the same time. And here's our aesthetics worked out. And again, just to confirm that lovely lower occlusal plane. From this, we also get our prep guides. So our prep guides are going to be a really, really important part, because our prep guides are going to form the basis of our tooth preparation to give the technician space. He needs to have ideal space so he can produce the definitive results so that they're in the same spatial position as the prototypes, and also have enough space to create the right color and effect. So these are our preparation guides. And this is a simple suck down, and this simple suck down is made over either the prototypes, or it can be made over a stone model of the diagnostic wax up. That's where they're usually made. So in terms of making the prototypes, we have our diagnostic wax up number 1. Number 2, we go and take impressions. When I say we, this is our technician. He takes impressions of the diagnostic wax up. Simple alginate. He now casts a model. So we now have a stone model upper and lower of the diagnostic wax up. He then takes his little suck down, and he creates a polypropylene suck down, a thin bleaching tray, call it what you will, over the stone model of the diagnostic wax up. From that, he then prepares the stone model of the diagnostic wax-up by preparing the teeth, individual teeth. He'll do full arch of tooth preparations. What's important here is that he knows what the restorations are going to be at this present time, and you know, and therefore, if you know what the restorations are going to be, you also know the thickness and the amount of space that the restorations need. PFM 1.5 millimeters occlusally, 1 to 1.5 millimeters labially. Emax 2 millimeters occlusally, maybe 0.7, 0.6 millimeter, up to a millimeter labially. Zirconia 1.2 to 1.5 millimeters occlusally, depending whether it's stacked or monolithic, and again probably anywhere between 0.7 and a millimeter labially. So all the different materials have got different space requirements. So number one, make sure your technician knows the materials that you're going to be using. And often I will use different materials at the front and different materials at the back. I like to use at the front of the mouth either Emax or zirconia for aesthetics, and then at the back of the mouth use something like PFM for strength, where the aesthetics doesn't need to be as good. So whatever it is, tell the technician exactly what you're going to be doing. And then he should, in collaboration with you, do a tooth preparation on the models, which is roughly half of what you will be doing. This will then allow him to make shell templates, shell prototypes, ones that when you come to fit them in the mouth, they fit loosely and you can reline them. So at the end of all this, this is how we make our prototypes. We've done those tooth preparations, approximately half the thickness of what it would be in the mouth. The technician now fills up the preparation guide with composite material, polymethyl methacrylate, something like that, puts it back on to the model, puts that into a pressure cooker, heat and pressure cooker, and heat and pressure cures, then takes it off, and hey presto, what you've got is the prototypes. All he does now is separates by cutting between the 4 and the 3, 4 and the 3, and then you get the 3 distinct parts of the prototypes. This is then sent to us, so this is making the prototypes. It's then sent to us so that we can go and use it to make sure that we're using the correct amount of tooth reduction, so the technician has the space he wants. And what I tend to do is I usually cut this into 3 parts. So cut the anterior part out, and I'll have an upper right, an upper left, and an anterior portion. And exactly the same for the lower. We cut it out so we have a lower right, lower left, and an anterior. And the other part that we then do is we drill holes into it. And by drilling holes in there, so just take a fine diamond burr and drill lots of holes in there, that allows you to use your periodontal probe to probe through, so you can now see whereabouts your tooth preparation is in relationship to the inside. Remember, not outside. These things have got certain thickness. So whereabouts is your tooth preparation in relationship to the inside of the tooth preparation guide? You know how much space you need. You go and probe with a perio probe. You can see how much space you've got. That will either tell you to stop, I've got adequate reduction, or to keep on prepping, so my technician will have the ideal amount. So we then go and use the prototypes and transfer, using the preparation guides, transfer our patient from the diagnostic wax up to the diagnostic wax up in the mouth. And we call that the prototype stage. And of course, we do that in stages again. Remember, we're increasing vertical dimension here. So the stages in which we're going to go through are, initially, I'm going to prep and fit the anteriors. So if it's a full mouth reconstruction, I'm going to have the patient in for a day. I don't want to be doing anything else. I don't have my mind thinking, I've got to finish by 3 o'clock because I've got another patient coming in. So this is 1 day set aside. I will go and prepare the upper 6 anteriors, lower 6 anteriors, reline the preparations, and then cement them and get my guidance and aesthetics sorted out. So that is a lot to do. So stage one is prepare upper and lowers. Now, as we do that, we don't do the definitive full preparation. We prepare grossly, and we prepare the margins to the soft tissue level. Maybe on some restorations, you're going to have a supragingival. Some restorations, equigingival. Some restorations, subgingival. Vertebrates, for instance, are going to be subgingival. But we're not going to go subgingival with our prototypes. So our preparation at this stage will be gross preparation to the gingival margin, the soft tissue, and then we'll take our prototypes and we reline the prototypes with Luxatemp over those preparations. Vaseline the preparations, fill the prototypes with Luxatemp and put them into position. Now it's interesting how we seat them into position. We have two ways of seating them into position. Number one, we can get a little jig which fits into the pallet, an acrylic jig, so that it seats the prototypes in the same relationship to the pallet that they are on the models. So that means that we get exactly the same fitting from the model to the mouth, because we're using a guide, we're using the pallet as a seating guide. Sometimes, however, we can improve. Sometimes, remember, when we've done our diagnostic wax up, we've not got the patient's face there. So the technician, by his doing all this work, and we put the prototypes in the mouth for the very first time to look at them, we might think, not quite right. They need to be a little bit longer. They need to be a little bit, the occlusal planes are not quite right. So sometimes we don't want to use a seating guide. We want to do it ourselves freehand. And in those situations, then I will come round to the front of the mouth, my Luxatemp into the prototypes, and then looking at the patient from the front, I will hold them in position so that the Luxatemp sets around the prototypes with my occlusal plane parallel to the eyes or lips, and with the right amount of proclination or retroclined, and with the amount of tooth showing that's correct. So we have two ways of fitting the uppers, and then of course we go and do the same with the lowers. With the lowers, I don't usually use a seating guide or seating jig. I do that freehand. So we've now got the upper and lower anteriors prepared, prototyped, with excess Luxatemp all the way around. We now take the excess Luxatemp away, and we trim and trim, and we trim to make sure that we have really good fitting margins. We certainly don't want to lose control of the gingival or periodontal condition at this stage. We want it to be as good as possibly can be. So we trim very, very finely, accurately around the margins, a fine diamond burr, tungsten carbide burr. We then polish, we put a glaze in place, and then we put the restorations, the prototypes in place with Tempron. Now, it's not just about aesthetics. At the same time as we're playing around with the aesthetics, getting the incised ledges correct, creating something that looks really nice and distinct for her in the mouth. At the same time as that, we're also playing with the occlusion. We're making sure that the lower six and upper six, when they're close together, we have 6 contacts. Remember, we've increased vertical dimension, so the back teeth are completely out of contact. So we want to make sure that we have lower 6 incised ledges contacting the palatal aspects of the upper 6. We'll then look to go into right lateral and left lateral guidance, and we'll make sure that the lower canine slides down the palatal aspects of the upper canine, and it's nice and easy movement to do. And that's important when the patient goes into a right and left lateral movement, that the lower canine slides very easily, shallowly on the upper canine, and we don't increase any stress there. And then finally, we'll look at protrusion. And again, in this case, where we've got good, healthy upper and lower anterior teeth, we'll have the lower 4 anteriors sliding on the palatal aspects of the upper 4. And at this stage, that allows us to do that adjustment. If we want all lower 4 incisors to be the same level, then we need to do more adjustment on the palatal aspects of the prototypes so that we get that nice, even sliding forwards. So we get the aesthetics right on the prototypes, we get the occlusion right on the prototypes, We then polish them, put Luxor glaze on top and cure that so they've got a nice shiny surface, and then we cement them with Templon. Now we go and wait, and we see the patient again either a couple of days later, a week later. We can leave it a little bit longer with the older patients, but remember the posterior teeth that are out of contact will not over-erupt very quickly with older patients. With younger patients, they will. So I'm quite comfortable scheduling this to, Monday we'll see you do the upper anteriors. I'll see you the following Monday and do the right side, following Monday to do the left-hand side. But eventually we'll get the patient so that they are prototypes all the way around. So here we are doing our tooth preparations now, and using the preparation guide. I'm using our periodontal probe to make sure that our technician has the space. And we're now taking the prototypes, and look how poorly they fit around the margins. That's because we have created shell prototypes that can fit in different areas. If we want, we can have a seating jig. Otherwise, we can just do it freehand. So in this instance, I've just done it freehand. Here now is I've filled up the prototypes with Luxor Temp, put it into position. And what you do get is a beautiful, just look, a beautiful, almost impression, if you like, of the prototype, of the gingival margins in the prototype. And that will then allow you to trim around those margins so you get a very, very good, precise fit. And exactly the same thing in the lowers. As you can see, we're not taking anything off the height of the lower anteriors, just preparing labially, and again, putting our prototypes in place. And once these things are fitting loosely, again, reline them. So we go through all these stages, and at the end of the day now, we've transferred her to a new vertical dimension. We've transferred her to a new incisal position. We've transferred her to a new even occlusal plane. We need to work with her now to make sure that she's comfortable with the aesthetics, that she's also can speak properly. This can take a bit of time. If we increase vertical dimension, we change the shape of the palatal aspects, then very often the fuzz and s words take a little bit of time to come back. So we need to work with her with phonetics. It's been shown with implant work where you take somebody who's wearing dentures and you put a fixed restoration in place, that it can take up to 6 months for patients to fully regain their phonetics. So I'm not anticipating that it's going to take 6 months here, but it could well take 3 to 4 weeks for them to speak properly again. And incidentally, when we're doing this with patients, it's the patient that feels that they're not speaking properly. The spouse thinks it's fine. The person, if it's me, the dentist, the nurse, thinks it's fine. You're speaking perfectly properly. But it's the patient who thinks, no, not quite right. And that, as I say, can take 3 to 4 weeks to occur. Now, our final end result. This is where our final end result is for the prototypes. And we're testing it. Phonetics okay, aesthetics okay, and occlusion okay. Let's just look and see what you think of this. Now, we've moved centerline across by about 1 to 2 millimeters. As you know, that will have an impact. What's it have an impact on? Has an impact on zeniths. So remember, whenever you are moving center lines, especially by a small or large amount, doesn't matter, you'll have a change in the zeniths. The larger the movement, the greater the change. So here now we look and we see with our central incisor, upper left central, instead of the zenith being slightly to the distal, it's bang in the midline. The lateral incisor, instead of the zenith being exactly in the midline, it is now slightly to the mesial. On the other side, instead of the zenith being just slightly to the distal, it's too much to the distal. On the lateral, instead of the zenith being in the middle, it's to the distal. So we've changed all those zeniths ever so slightly. What can we do about it? Well, number one, we can do nothing. And the patient, most patients do not understand that zeniths. We're doing the zeniths for ourselves. We're not doing it for the patient. So number one, don't do anything about it. Leave it. Number two, we can ask our periodontist to take this into consideration when he's doing his periodontal work. As I mentioned, this is gross work, and very seldom is he going to be able to do all of this in one go. If we want to do anything with a periodontist, then it has to be a second surgical procedure. And we can ask him to do a second surgical procedure. What will it involve? It's not just going to involve a little bit of gingivectomy here, because if you just do a little bit of gingivectomy there or a little bit of gingivectomy there to get the Zenith looking correct again, then that gum will just grow back. So it does need some bone contouring underneath it. So that's the second. The third thing to do is we can now change the sub-emergence profile, and we can start to make the emergence profile greater than 30 degrees in some areas, less than 30 in other areas. So remember, our sub-emergence profile, the teeth come out at a 30-degree angle. Make them come out at a 60, 70-degree angle like this, and what happens, the soft tissue will go up a little bit. It will recede a little bit. From that 30 degrees, ask the sub-emergence profile to come out at 10, 15, 0 degrees, and the soft tissue will come down a little bit. So what we can do in these sorts of areas is just play around with the sub-emergence profile. What that means is we have to do this on the prototypes. So if this was the case and my patient was in the slightest bit bothered, we would take the prototypes off, and I would now start to add a little bit of material just here to bulk it out and maybe thin out underneath. Same thing here. I'd have to add a little bit more material just there. If I add material, I'll get recession. So I will now change the levels. And that can take maybe 3, 4, 5 visits over a 3-month period. Is it worth it? Only you, your patient, can tell that. But that is what we would do if we wanted to get it exactly right. So let's imagine your Zeniths now are exactly as they are. You're going to go and re-prepare and take your definitive impressions. How can your technician make the sub-emergence profile exactly the same as the prototypes? He needs to have an impression of the prototypes. But that is not just a normal alginate of the prototypes in the mouth. That is taking the prototypes out. Let's just go back a couple. There we go. Taking the prototypes out like this, and then holding the prototypes by the incisal edges, and now pushing the gingival margins of the prototypes into impression material. So we actually take an impression of the gingival margins of the prototypes out of the mouth. Technician can now pour a model into that, and he can then get the prototypes in a solid material. He can scan them, and he can use that scan to then make sure that the definitive crowns have that same sub-emergence profile. Lots of work involved, but it is possible. So these are the stages. This is now with my patient fully prototyped. And this is now with my patient about 2 to 3 weeks later. The soft tissue's healing nicely. We're playing around with the aesthetics, phonetics. The soft tissues here, from a patient's point of view, totally happy with them. Doesn't want anything doing, thank goodness. If we did need to do something, it's either back to periodontist or, as we've mentioned, to go and get the Zenith correct, we'd start to play around with the sub-emergence profile. Now we go into our restorative phase, and this is our definitive stage now that we're going to go into. And we have to make sure every single case, full mouth reconstruction or partial reconstruction, it doesn't matter. We do it exactly the same way. Always do the anteriors first, get the guidance sorted out, then do the posteriors. We have to make sure we have our 5 principles of occlusion in place. Make sure you're working around RAP. Absolutely essential. Full mouth reconstruction, you work around RAP. Absolutely essential. If you're increasing vertical dimension, you work around RAP. You make sure the muscles, the ligaments, the joints, and the teeth are all working in harmony. Make sure we've got a mutually protected occlusion. My front teeth are protecting the back ones protecting my front. My anterior guidance is correct, and by that I mean that the 6 anteriors in right and left lateral excursion and protrusive are discluding the posteriors by enough. How much is enough? usually 1 to 2 millimeters of disclusion. That's all we need, and that gives us nice shallow guidance. Again, just going back and making sure no balancing side contacts, I've got enough disclusion, and I've got good posterior stability. I'm now, with those thought processes, going to go and do my definitive work. So I'm now going to take my patient from the prototype stage to the definitive stage. And for this, we do it again in stages. So we're now going to use 1, 2, 3, 4, 5, 6 different stages to go and transfer my patient from prototypes to definitives. And we start off and we do it exactly the same routine. Anteriors first, posteriors second. So once our patient's happy and you're happy, we can start on the final stage, which is number 1, take off the upper and lower anterior prototypes, re-prepare them, prepare them so that the margins are now, if needs be, subgingival. Now, also important at this stage is that we go and measure the thickness of our prototypes. It can be, if we just go back a couple of photos, it can be that to go from this stage, this is initially me putting the prototypes on. I've finished those 3 stages. I'm now going to get the patient back and we're going to talk about what you think about the aesthetics. Maybe our patient at this stage says, you know what, I think these 2 front teeth and that lateral incisor there, they stick out a bit. I'd like them moved back a little bit. And you say, fine, I can do that. So we adjust them and we polish them and we get something which the patient is now more happy with. And let's just say I've taken 0.5 millimeter away. Now that's a big problem because my prototype is now 0.5 millimeter less thick than it was. If I'm going to create exactly the same shape and position of the labial surface, I've lost 0.5 millimeter of space for my technician. So by taking the labial aspect backwards, when I come to do my definitive preparations, I've got to also prepare the labial aspect 0.5 millimeter further back. So the way that we understand this is by measuring the thickness of your prototypes. So always a good thing when we're taking our prototypes off, whether they're anteriors or posteriors, to measure the labial aspect, buccal surface, see how thick it is, make sure that it's the correct thickness for when you're going to have the definitive material there. So again, PFM labeling on an upper 6, maybe I want 1 millimeter, 1.2 millimeter space, take my prototype off, my prototype is 1 to 1.2 millimeters thick. I can measure it. Same thing occlusally. Take your prototypes off at the back of the mouth, measure occlusally. Have you 1.5 millimeters that you need for your PFM? If you've only got 1 millimeter, you therefore need to go and prepare a little bit more, an extra 0.5 millimeter off the occlusal surface, so you have the correct space. So this is using your prototypes now as your final definitive preparation guide. So remember, always measure your prototypes. Make sure the thickness is the same thickness that you're going to be using on your definitive restorations. Otherwise, we're going to have a problem. We need to have a timeout and think. So we re-prepare upper and lower anteriors. We put our retraction cords in. We do our final impressions, upper and lower. We'll do a face bone. We will do our jaw registration. Now we've reshaped the margins. So we have to take those prototypes and reline the margins. So I'll now take the prototypes, add material Luxatemp, syringe them around the margins of the preps and seat them back in place. So I'm now again going to get a good impression with the Luxatemp that I can trim around so I don't lose control in this stage of my soft tissue. So we reline and we refit with temp bond again. And the final thing we do is then take impressions. And we take impressions of the prototypes in the mouth so our technician can see the shapes and if needs be, copy the shapes with various indices. So it's really important that he knows the end result. The end result is your prototypes. And what you're trying to do is say to him, copy please the prototypes. So he's got all the information he now needs to go and do his upper and lower definitive crowns. So the upper and lower definitive crowns come back to us. He might use buckle incisal indexes to get the correct shape. He might use a custom-made incisal guidance table. We talked to you previously about lab communications. If you wish, go back and listen to the lab communications lecture which I gave, which talks about all the different things our technician can do to help us. And it's so important that you know them all, because otherwise you won't be able to ask him to do these things. So we now fit our upper and lower anteriors definitively. They should be a copy of the prototypes. They should look nicer, but generally the same. Okay, our next stage is our patient comes back the week later. So between 1 and 2, it's usually a couple of weeks for me, sometimes 3 weeks for my technician to do that work. Patient then comes back a week later and we start to do one side. So let's say it's the right hand side. I'm going to take the right hand upper and lower prototypes off. I'm going to re-prepare again, make sure my margins are exactly where I want them to be. We're going to take, with some retraction cords, some impressions, I'll take another face bow. Every single time I'll take a face bow. I'll take a jaw registration between the preparations. Okay, not all around the mouth, but between the preparations. Reline and retrofit the prototypes, and then take impressions of the prototypes, of the full arch. Again, the technician knows the shapes that he's working to. 2 to 3 weeks later, he sends back the definitives, and we now fit the upper and lower posteriors on the right-hand side. Week after that, we now go and do the left-hand side, and we do exactly the same thing again. Take the left-hand upper and lower prototypes off, re-prepare the margins, measure the thickness of the prototypes, make sure they're correct. If not, re-prepare again. Put your retraction cord in, do your impressions, do your jaw registration, do your face bow, reline your prototypes, take impressions of the prototypes. The same thing again. This gives you, what's the word we're after? Predictable end result. We know we're doing everything the same way again and again and again, and we get predictable end results. And then we fit our upper and lower posteriors. So here we are doing our definitive face bow. Here's my final case in the lab with our technician doing the ceramic work. These are zirconia restorations that he's doing. Same thing in the lower. Palatal surfaces, incisal edges. And we're doing our posteriors. Mixture of crown preparations and porcelain inlays, one side. Other side, porcelain inlays, crown preparations, and an implant. On the upper side where we're missing a tooth, we're also doing a fixed movable bridge. End result is that we've now got all our anteriors fitted. We've got the same nice even occlusal plane. We've got what we want, which is golden proportion, correct width to length, gingival margins the same, guidance nice and shallow. Look at the palatal aspects there. I'll just go back 1 or 2 slides again. Look at the palatal aspects there. Really important part. Labial aspects are there for aesthetics. Palatal aspects are there for function. So don't bother with the palatal aspects saying to your technician, give me marginal ridges, give me cingulums. I don't want that. I want a nice, smooth, incline plane so that my lower canine can slide across there beautifully, not going over lumps and bumps where the technician has tried to create natural anatomy. Don't recreate natural anatomy palatally. Palatally, you want smooth inclined planes so that lower teeth can smoothly move from side to side. Really important part there. Same thing with the lower, and again, that beautiful wax up we had with the very even occlusal plane, the prototypes with the even occlusal plane, and then the definitives with the even occlusal plane. Lower incisors a little bit longer. So there's our Final restorations. We're going to protect with an occlusal splint because she's a clencher and grinder. And we look at the definitives. So here's the definitives. This is where we started out. This is where we've now finished. She's got a lovely smile. And let's start to look at the face as well. So this is where we started. This is where we finished. Now, this is the joy of doing this work. We've now not only given her a nice smile, okay, she's got a good set of teeth there, look very, very nice, but look at the face, look at the brightness in the eyes, look at the length of the face is better, look at the nasolabial folds, look at the general lips, look at the eyes. The eyes seem to be a little bit fuller, they seem to be further forwards, not as deeply set. All in all, she looks healthier, she looks younger. We've taken probably, if not 10 years, 5 to 10 years off her. This is also called the dental facelift. And it's an important part that when you're talking to your patients, you show them photos like this. We as dentists are in such a valuable position that we can not only change smiles, we can change faces as well at the same time. If you take a little bit of notice and you start to understand facial aesthetics, vertical dimension, full mouth reconstructions. So thank you very much for listening. I hope it's been of some use to you. I'm happy to take some questions now. There'll be lots more case studies coming along. So please look out for them. They'll be done in exactly the same format where we repeat an awful lot of what we're saying because repetition makes it perfect. So I'm going to take some questions now and we'll see what people have got to say. So let's open up the Q&A system. Okay, so our first question. Please, does the golden proportion apply to the actual teeth width or the width shows when they look in the anterior view? Okay, Ridya, you're very correct. The golden proportion is as we're seeing from the front in 2 dimensions. So it's as though you are taking a photograph and looking at a photograph. Obviously, we look at things in 3 dimensions because we've got 2 sets of eyes. We can look round corners to a certain degree. So it is not the true width. So the canine may be that wide, but by the time that it's at a slight angle, it only looks a little bit, it only looks a certain width. So it's very much a 2D view. So it is the perceived width that we see looking at a 2-dimensional picture. Otherwise, again, close one eye and look at it with one eye. That gives you the 2D vision. Thank you for your question. And another one, Bridget, do you have a fixed proportion recommendation to follow regarding the height to width of centrals? That proportion is 75 to 80%. So that's what I'm looking for whenever I do my width to length ratios. My technician understands that, so he knows that whenever he gives me a central incisor, has to be in that proportion. If it's not going to be in that proportion for whatever reason, he needs to come back to me and tell me why. And then I have to start thinking during my treatment planning, how do I change that? Do I change it or do I leave it with a non-ideal proportion? But usually it's 75 to 80%. The width is 75 to 80% of the length. The length is always longer than the width. And in this case, as you saw, certainly the upper right central incisor, the width and the length were the same. Okay, an anonymous question. What are my thoughts on pre-op ortho versus perio surgery to correct and improve gingival levels? Absolutely. I've got some case studies which I'm going to be sharing with you that go through preoperative orthodontics beforehand. I would normally not do them just to create gingival profiles. I usually do my orthodontics so that we can get teeth into the correct region, so I can then minimize my tooth preparations. So absolutely, as an alternative, yes, it can be. So instead of doing the crown lengthening, we could have intruded the teeth. The crown lengthening will probably take less amount of time than the orthodontics. And a lady like this didn't particularly want to go through orthodontics. But very, very valid question, and in some situations we'll turn to that. Another anonymous one. With regards to longevity, how often would you expect to have crown failures, fractures on small teeth, upper laterals and lower centrals? I certainly wouldn't expect to have fractures. If you're thinking of the tooth fracturing off at gum level, no, I'm not expecting that at all. That's a very unusual thing to happen. In terms of longevity, I can say that you're looking for most of your restorations, your indirect restorations, to be lasting a minimum of 15 years. I'd like them to last longer. If we look generally at, let's say, PFMs, again, we don't have the longevity of EMAX and zirconia at the moment. And the reason for that is that EMAX and zirconia has changed over the years. So we can go back and look at zirconia restorations that were done 10 years ago, and we have 10-year success levels. And that will show us at the front of the mouth, roughly 95% success, at the back of the mouth, roughly 90%. The problem is we're not using that zirconia now. The zirconia that was used 10 years ago was very, very dense, opaque, and very, very strong. We're using translucent zirconias now, nowhere near the same strength. And this is one of the problems we have when we start to look at longevity studies, is that the materials start to change. The one thing we've got is great longevity studies on PFM and gold. Why? The material's not changed over the years. And if I've got a patient now and I'm looking the patient in the eye, I'm going to say structurally, your PFM will last, I would think, on average 30 years. Aesthetically, yes, you may get anteriorly, you may get a little bit of recession, which may mean that the margin's going to be shown, which may mean that you will need to get that crown replaced more earlier than that. But from a structural point of view, my PFMs, I say, should last up to 30 years. For gold work, you can be looking at 45 to 50 years for gold work. Tucker did a lovely study, and he looked and shown that he's got over 90% success rate at 43 years for his gold work. So very much depends on materials as to longevity. However, I would not expect fracture. If a tooth's fracturing, then you've over-prepared it, or it's gone non-vital. Okay, on to the next question. Again, anonymous. What are my thoughts, tips on avoiding soft tissue staining when using astringent? It's only transient. So it will stain, but it's only transient staining. So I wouldn't worry about it. The staining goes by the time that you see the patient again, 1 to 2 weeks later, that stain has gone. So wouldn't worry about it in the slightest. It doesn't bother me in the slightest. The astringent should not stain the tooth at all. Wash it off completely. But with soft tissue, it's just there for a short period of time. Now, the problem that the astringent gives you is that very often you have a black coagulum which forms in the tissue. And that can be a problem. That can be a problem when you're taking impressions, that you got this great big thick coagulum that forms. And that coagulum has formed because your nurse has been aspirating too close to where you're putting the astringent material. Remember, here I'm saying astringident, I'm not saying astringent. My favorite astringent material is an Optident product called astringident. Clear liquid, absolutely tastes foul, but it's a clear, maybe slightly brown liquid, which you then syringe with a amount of force, like you burnish it into the tissue. Important, you burnish it into the tissue. Important, you use lots of it. Important, you aspirate a long way away from it. Do not allow the tissue to dry out. The tissue dries out, you get this horrible black coagulum. So I hope I've answered your question there. What material do I use for a unilateral bite record? There are two common materials. The one I like to use is Duralay. Duralay hard acrylic. The models either go together or they don't go together. The other ones that you're going to be using, I certainly wouldn't use wax. Don't use wax. So it's either bite registration paste between the opposing preparations or Duralay. My favorite is Duralay. For that, we Vaseline the teeth We bead some duralumin onto the upper tooth, onto usually a cusp tip, add a little bit more, and then we gently tap our patient together. And so a lower cusp tip will go and indent into the duralumin. So I get a very, very rigid material. At the final prep stage, we take impressions for preps as well as to the prototypes. Absolutely, yes. We take our definitive impressions at the final stage for our definitive restorations. We then put the prototypes back in place, patients ready to go home, and finally we take impressions of the prototypes still in the mouth. So the technician can see what's going on in the mouth. The technician can see the shape of the prototypes. Remember, ideally what we want to do with our technician is just say, copy. Please just copy. I don't want to do any changes, because if you have to do changes, the patient's not used to that. So if your prototypes, you suddenly decide your prototypes are 1 millimeter too short, and the patient says, I want them longer. You can't just say to your technician, make the prototypes, make the definitives 1 millimeter longer, because the patient may not accept them. The patient's got this idea that they'd like them longer, but when it goes back into the patient's mouth, the patient very often might say, no, I prefer it as it was. So you then have to add on to the prototypes, get the prototypes right in terms of shape, then simply say to the technician, copy, nothing else. Next question. This is from Katrina, if I have localized anterior wear, can't you use a dial appliance, not repair all the posteriority? Yes, of course, Katrina. You've got options. The lovely thing about restorative and aesthetic dentistry, there are options available to you. We're doing a treatment planning session on Monday of this particular week coming up. And I'll be discussing over 4 hours. I've got it over 2 weeks, next Monday and the Monday after. 2 hours of treatment planning, and again, a further 2 hours of treatment planning. This is not individual case studies. We're talking here about all the different alternatives. And you will see if you listen to that treatment planning webinar, that we've got so many different options that we can give to the patient. So this is one option that the patient decided. The patient wanted to get rid of the amalgams. The amalgams had fractured the teeth, the small fractures. So it is either doing onlays or doing full crowns. And the patient decided that she'd rather have the onlays on some teeth and full crowns on others. Hence we did, as you saw, some porcelain inlays and onlays on some, full crowns on the others. But yes, an alternative would have been a dollar appliance, of course it would. Shista, yes, hi. During the prototype stage, using the splintered prototypes, especially in the case where periosurgery has been done, is there any impact on the gingiva? Using splintered prototypes, the impact is that the patient has to understand they need to use floss threaders. They obviously cannot use floss. So there is always a potential impact of the patient not cleaning well interproximally. At this stage, I don't like them to use the brushes. That can come later. But at this stage, I want them to be able to use the super floss and get the super floss in between the embrasures at the gingival margin. Next question, using the prep guides, can we measure depth of prep? But we just eyeball the prep to see the planes of reduction when we are doing this? So planes of reduction, yes, remember that our final diagnostic wax up will have a convex surface. Therefore, when you're using the prototypes will have a convex labial surface. The preparation guide, the internal asset, will have a convex preparation surface. So we will use that by having depth cuts, but also by taking the perio probe at the gingival third and measuring, in the middle third and measuring, and in the incisal third. So that you can put as many little diamond burr cuts, holes, as you want to. You can almost obliterate the whole prep guide with lots and lots of little holes. That will tell you where the space is. And if you do that, that will give you your 3-plane reduction. Anonymous again, what do you think about restoring these complex cases with composite? Yes, another option. Nobody is saying to you that this is the only way you can do things. We can do it with composite. However, by using composite, one of the problems we have is staining and wear. Composite will not last as long. Certain patients are younger patients. Most of them, I can't speak for every single one. This is where we need to gain consent and have a proper discussion. But a lot of younger patients would prefer, they've been brought up, they've got very, very good teeth, healthy teeth, and probably more ideal is minimal intervention and to have composites. Our older patients, and I can say I'm one of them. I've got crowns on my upper anterior teeth, bridges here, crowns on my lower anteriors, and the odd crown dotted around. Those crowns have been replaced, but I've not lost any teeth over the years. I've not had to have any teeth root filled. For me, doing crown work works very, very well. And the advantage for me is that somebody my age, I do not like having to go to the dentist again and again and again and having work done. I would prefer to have something done which will last longer rather than with my lifestyle going back and seeing the dentist every 6 months or 9 months, etc. So it depends what is your personal experience of ever having composites or crown work done. I've got composites in my mouth. They last 3 to 5 years. It seems as though I'm going back to the dentist again. I've got crown work in my mouth. I have a Go crown down here at the bottom that's been in place 35 years. I've got a PFM at the top here, been in place 35 years. So for me, I will get a much, for me personally, better longevity and restored case doing something with a harder material. Now, it all depends upon your experience as a dentist, the patient's experience as a patient. And what we cannot do is push our ideas onto the patient. We have to go and say, this is the longevity of one material versus another. This is the tooth destruction of one material versus another. This is the aesthetics of one material versus another. And the patient decides. End of the day, the patient decides. So yes, we have different materials we can use and the patient decides. Next question. What influences overjet and overbite during vertical dimension raising? Is it similar to a natural dentition? We try to get a class 1 wherever possible. I'd like to get a class 1 occlusion in place with a, I'd say, average. So my lower incisors hitting in the cingulum area with about 5 millimeters of vertical disclusion. So I'll try to, whenever possible, go to a normal overbite and overjet. That may mean that I have to recontour, reshape the palatal aspect and bring the upper palatal aspect down. Because remember, if we've got natural palatal contours and our teeth are like this, as soon as I increase vertical dimension, I either, to get contact, have to make the lower incisors longer, in which case I'm going to affect aesthetics, or I have to bring the palatal aspects down. So you'll notice that most of the cases that somebody does with an increased vertical, the palatal shape has gone from being concave with anatomy to something that's either flat or even sometimes convex, because we've got to bring those palatal aspects down to hit the lower incisors. So we can get contact. Remember, to have disclusion, you've got to have contact. And we can then try to wax in our ideal overbite and overjet. Every case is different. And of course, we work this out on our diagnostic wax up. We have a case study coming up in a little while where we have gone and taken a class 2 patient, a class 2 div 1 patient. And of course, with a class 2 div 1, already like that, I cannot create a class 1 occlusion from that. So we have to look at different ways of getting guidance. And sometimes we have to go to long centric for cases like that. So there are options, but work it out all on the diagnostic wax up first of all. Shista, another question. During prototype stage, are we working to RAP? Absolutely. We check the 5 principles. Absolutely. How can we check if the muscles are happy? Load test the joint. Yes, always load testing the joint beforehand. How can we test if muscles are happy? We can prod them. We can do the force testing. But generally, we're looking to see that our patient just feels comfortable. Asmita, also, what is the sequence, the cementation of the full mouth rehab? So with cementation, we do anteriors first, then posteriors. So you'll see that we're doing it in stages. So if I've got the upper 6 and lower 6 to do, I'll start off with my 2 centrals. I'll then move on to my 2 laterals and then do my 2 canines. That's if I'm using something like resin modified GIC or GIC. If I'm using zinc phosphate, I'll do all upper 6 at the same time. Once I've done my uppers, then I'll go down and do the same protocol for my lowers, either 2 by 2 or all 6 if I'm using zinc phosphate. Predictions for England versus West Indies. Interesting one. I could talk for a long time on that, and I'm sure that you'd all enjoy that talk. I think the West Indies might give us a little bit of a shock. I think our batting is still very, very fragile. I think the West Indies pacemen have got decent pace to them. I think that they could, give us a bit of a shock. I do think the West Indies batting, however, they're missing 1 or 2 guys who've not come over, and I think the West Indies batting just will not be good enough. So I think we'll win the series. Ridya, in case of the prep guide shows enough space, i.e. only additive material, do you still prep a finish line? Depends on what we're trying to achieve. I don't know if you caught the presentation I did yesterday on margin design. So if you're using the materials such as zirconia, then you can easily finish subgingivally with a vertiprep. Vertipreps are very, very in at the moment. We can do a vertiprep for Emacs, for veneers. And that vertiprep, basically, we call it a non-preparation veneer. And all we have to do is find a path of insertion. So some of these cases, the non-prep ones, are even more difficult to do because you're so used to prepping teeth. Now, when we're not prepping teeth, we've got to still find a path of insertion. So we don't see finish lines. It's no good having a path of insertion where you see a finish line. So your finish line usually has got to go past your contact area. So you have to get rid of bulbosities and either have a path of insertion which comes this way, labially, or a path of insertion which comes incisally. So your preparation guides will show you where the depth needs to be, where you need to have that material. But if we're doing additive, then you've also got the Gallic-Gorel method, build it all up in composite, and then use a burr to go and take down 0.5 millimeter. So you might be prepping some tooth, or you might just be prepping composite. But you don't always need a finish line. That's the point. Nowadays, we're going more and more away from distinct finish lines, such as chamfers, bevels, etc., towards the vertiprep. And remember, the vertiprep, it's a prepless margin. It's a feather edge margin. There must be a margin there under a microscope, but under normal eyesight, you can't see it. Again, another anonymous one here. Which lab do you use for complex cases? I have several labs which I use, and I'll go through them. I tend not to use labs, but individual technicians. So the technicians which I will use, Marco Bacisa in Cornwall. Martin Fletcher works at Swift in Manchester. Phil Reddington over in Yorkshire. Those are the technicians I use for most of my work. Depends where the patient is in the country. Depends if the patient's willing to travel for shades and those sorts of things. And without having to go into it in an awful lot of detail, certain technicians are better at different techniques. Those are all beautiful technicians. The fourth one I should be mentioning, Gary Jenkinson, also from ART in Sheffield. I use him as well. And as I say, it could be any of those four. Next one, any tips on the size of connectors in the prototypes to improve oral hygiene? Okay, nice one. When you've relined, you are obviously having probably a bulk of material around that gingival papilla. So we then tried, once we realigned, we trimmed, we then try the prototypes in, and what I don't want is too much or too little space. So if my connector and the gingival part of the connector is impinging on my papilla, then I'll start to take some away. We've also got the Dennis Tarnow study that we can be having in the back of our mind, but I tend not to use that for my prototypes, just use that for the definitives. So I give my technician always whereabouts the interdental bone is. And we've also got the aesthetic part, and this is what I use for my provisionals prototypes. I make sure that the length of connector is 50% of the length of the central incisor. Between the central and lateral, it's 40%, between lateral and canine, 30%. So aesthetically, we get the right one. Good question, thank you. Another anonymous one. Very good presentation, sir. Please, could you give your thought if GIC can be placed with EMAX? No, no. With EMAX, it is only a composite luting cement that's strong enough. So GIC, resin modified GIC, sorry, no. It will fracture. Raddy, in today's case, it was more conservative to do veneers in the lower anteriors or crowns. Again, great question. For me, I'm looking at the amount of dentine that's on display, and I'm thinking, is that going to affect my bonding for veneers? So once I've done my preparation, I'll have a lot of dentine on display. I'm also looking at the longevity with dentine on display. So we know very well from studies in the States that our longevity for veneers when we're bonding totally to enamel, 90% plus over 15 years. Here with a lot of dentine, I'm not going to get that success rate. Also bear in mind, if I'm going to do full crowns, then I'm looking to try to get 30 years out of them. Anteriorly, maybe I'm going to get 15 years or something like that. Probably longer than I would do with veneers bonded onto dentine. So that's my thought process going through things. Certainly, in this case, the zirconia crowns are going to be much stronger than veneers if my patient's a clencher and grinder. So my patient's clencher and grinder is wearing a splint, yes, but I don't know if the patient will actually wear the splint or not. The patient may decide at some stage they can't be bothered. They may lose it and not come back to me, in which case my veneers would more likely fracture with heavy grinding, where my zirconia has got a good chance of not fracturing. So it's all about longevity, all about tooth destruction. Remember, our patient wants three things. We want three things from a restoration. We want maximum longevity, we want maximum aesthetics, we want minimum tooth prep. And also remember, we cannot get all three into a restoration. Impossible, cannot be done. If we want the maximum longevity, we go to gold. If we want the maximum aesthetics, we go to feldspathic porcelain. But remember, gold doesn't look as good. Feldspathic porcelain won't last as long. Okay? And so all the materials we choose, we can only ever get 2 out of the 3. And the person that makes the decision is not you. The person that makes the decision is the patient. The patient decides. You tell them about the materials and techniques that you can use, what longevity it gives you, what tooth destruction it gives you, what aesthetics it gives you, and then the patient decides. Next question, anonymous. If a patient with a class 1 with a horizontal chewing pattern, do you also finish the case with freedom eccentric? No, I'm not a freedom eccentric person. I'll only go to somebody with freedom eccentric if their mole feeding position means that they're uncomfortable. So I would more likely give shallow guidance to a horizontal bruxa, certainly not going to give steep guidance. That also means at the back of the mouth, I'm going to have shallow cusp angles so that they disclude more easily. I can have shallow guidance, but I'll only use freedom eccentric, and that's long centric, wide centric, for cases where my patient is uncomfortable with the prototypes in place and feels locked in. Otherwise, no, I don't. What is my protocol for removing prototypes? Okay, that's a good one. So my protocol for removing prototypes is very simple. Let's look at 6 anteriors here. With 6 anteriors, you have obviously 5 contact areas. So push some superfloss between the contacts and then tie it off as though it's a suture. So you've created a loop. So do that between all 5. So you now have 5 lots of floss hanging down. My nurse holds the floss and pulls vertically. And I now go around the margins with a excavator, trying gently to prise them off. Also, make sure that when you're using 6 splinted units, don't use full temp bond. Put a little bit of Vaseline in as well, so the temp bond doesn't actually set fully, and you can pull them off, more easily. So the nurse pulls with the floss really hard, literally pulls as much as she can, and that's making sure that the prototypes will come off down the long axis of the preps. That means it will not fracture a prep or fracture a prototype, and you just gently ease them at the margins. And don't use full tempo. Next one. Please can I explain again the first visit of the definitive stage, especially the impressions. Definitive stage, okay, I've got the full mouthpiece prototype. So number 1 stage, take upper and lower prototypes off. Measure the thickness of your prototypes to make sure you have the correct space. Whatever material you're going to use is your definitive. You have to have that space, that thickness of your prototype. And that's labially, palatally, incisally, occlusally. If you don't have that thickness on your prototype, you need to re-prepare. So we take the prototypes off, we measure the prototypes. We see any areas of the axial walls or occlusal surfaces that we need to re-prepare. We go and re-prepare to get the correct amount of space. We then go and put our retraction cords in place, and we prepare down to our new margin. We define the margin. Remember, my margins initially are equigingival, so I'm not going subgingival. Most of my margins, if I'm going to be cemented anteriorly, as in this case where we're using zirconia, it's going to be a subgingival prep, usually now vertipreps. So I will redo my margin and then I'll take my impression. So number 1, remove prototypes. Number 2, measure prototypes. Number 3, re-prepare axially, occlusally, incisally if you have to. Number 4, re-prepare margins. Number 5, take impressions. Number 6, jaw registration between the preps. Number 7, face bone. Number 8, reline the prototypes so they fit the new margins. Finally, number 10, take impressions of your prototypes once they're seated back in the mouth. That's our protocol. Okay, guys, that is all questions finished. Thank you very much for listening. I hope you've enjoyed it. We're now going to finish. So thank you very, very much for your attendance, and I'll see you at the next time. You've got everything there in front of you. If you wish to subscribe to the rest of the webinars, then please go to tiptontraining.co.uk, www.tiptontraining.co.uk. Please tell your other friends, colleagues that we're offering all of these webinars, probably 5, 6, 7, 8 webinars every week free of charge. Some of them are chargeable, some of them go out to the groups that we're already teaching, but we do 5 to 7 free of charge webinars every week. Please tell your friends about that so that they can subscribe as well. If you need to ask me any further questions, my personal email is drpaultipton@gmail.com. And if you want to get a recording, then you need to go and speak to Louise, www.louiser@tiptontraining.uk. Okay, thank you very much indeed. Nice to see you. We'll see you again sometime. Take care.